A lecture on GI pathophysiology. Disorders of the stomach. The gastric mucosal barrier is the property of the stomach that allows it to contain acid. There are two basic causes of ulcer formation, and they are decreased mucosal protection and increased acid production. If the barrier is as by aspirin in acid solution, acid diffuses back into the mucosa where it can cause damage to the stomach itself. The barrier consists of three protective components. These provide the additional resistance for the mucosal surface of the stomach. The three components include 1. A compact epithelial cell lining. Cells in the epithelium of the stomach are bound by tight junctions that repel harsh fluids that may injure the stomach lining. The second protective component is the special mucus covering. The mucus covering is derived from mucus secreted by surface epithelial cells and mucosal cells. This insoluble mucus forms a protective gel-like coating over the entire surface of the gastric mucosa. The mucus protects the gastric mucosa from autodigestion, for example, by pepsin, and from erosion by acids and other caustic materials that are ingested. The third protective component consists of the bicarbonate ions. The bicarbonate ions are secreted by surface epithelial cells. The bicarbonate ions act to neutralize harsh acids. So for every hydrogen ion that is excreted, a bicarb is produced. As long as the hydrogen ion secretion is equal to the bicarb production, then mucosal injury doesn't occur. Prostaglandins increase mucus secretion in the stomach by stimulating mucus cells and increasing bicarb production. Molecules within the prostaglandin family, such as arachidonic acid and COX, etc., also mediate inflammation and pain. NSAIDs block these pain or inflammatory pathways, but in doing so, they also decrease mucus secretion in the stomach and decrease bicarb production. This is the reason that prolonged NSAID use can cause ulcers. For review, there are two basic pathos for causing ulcer formation: decreased mucosal protection and increased acid production. The ingestion of NSAIDs is a risk factor for the development of peptic ulcers because they decrease the production of bicarb and prostaglandin synthesis. Bicarb neutralizes while prostaglandins stimulate mucus production. Infection with H. pylori is one of the most common causes of ulcer. H. pylori leads to ulcer formation by both decreasing mucosal protection and increasing secretion. What happens is that the bacterium damages the mucosal lining and creates an inflammatory process that leads to increased acid secretion. The mucosal barrier serves to protect. If the mucosal barrier is not intact, hydrochloric acid will enter the mucosa and injure the underlying tissue. This is a pathoschematic of what we just discussed. It reviews barriers to ulcer formation, such as your tight cellular junctions and hydrophobic layer, the mucus layer, and prostaglandins. In terms of the hydrochloric acid, it enters the mucosa, it destroys cells, and it triggers the inflammatory response. Histamine is then released from the damaged cells. Histamine then sits on H2 receptors in the GI mucosa and stimulates acid production. So further damage occurs, and that ultimately leads to ulceration. Release of histamine also mediates vasodilation and increased vascular permeability. So this is where mucosal edema sets in. This figure depicts your normal versus injured mucosa, so please take a look at it. Gastritis. Gastritis means inflammation of the gastric mucosa. It can be acute or chronic. Acute usually entails transient or momentary inflammation. Irritants can be NSAIDs, alcohol, or H. pylori bacteria. Chronic gastritis. Chronic gastritis is progressive in nature and is classified according to its patho. For example, you have type A, the immune or fungal form, and then you have type B, the non-immune or antral form. The type A form is rare, but it's also more severe when it does occur. It results due to an autoimmune response to parietal cells. So you have the gastric mucosa that degenerates, and there's loss of parietal cells as well as chief cells. And as a result, there's a decreased secretion of pepsinogen, hydrochloric acid, and intrinsic factor. Because of that, you have vitamin B12 absorption, and that leads to pernicious anemia. Type B is 4 times more common than fungal gastritis. It's not associated with decreased hydrochloric acid secretion, pernicious anemia, or parietal cell antibodies. Factors associated with type B are alcohol, tobacco, and NSAIDs. Recall that NSAIDs block prostaglandin synthesis. Alcohol and nicotine and tobacco stimulate acid secretion, so that irritates the stomach lining. With H. pylori, you have the release of cytokines that damage the gastric epithelium. Signs and symptoms for acute or chronic gastritis include vague abdominal discomfort, epigastric tenderness, fullness, nausea, vomiting, anorexia, and gastric bleeding. Management consists of managing the symptoms with smaller meals, a soft, bland diet, and avoidance of alcohol and NSAIDs. Combination of antibiotics are used to treat H. pylori. Vitamin B12 is administered to correct pernicious anemia. Peptic ulcer disease. There are 2 types of peptic ulcer disease, and they are duodenal and gastric. 14.5 million people in the U.S. have peptic ulcer disease. And risk factors of either type consist of smoking, H. pylori, because it damages the gastric epithelium, habitual use of NSAIDs, they affect prostaglandin synthesis, alcohol and caffeine, which both stimulate hydrochloric acid secretion. Smoking does the same thing. There's steroids or glucocorticoids. They decrease the renewal of the mucosa and increase hydrochloric acid secretion. They also have vasoconstrictive effects similar to norepinephrine and epinephrine on alpha receptors, leaving the cell susceptible to hydrochloric acid. And then there's stress, which has a similar effect to steroids. In terms of the pathoschematics for both the duodenal and the gastric ulcer, you'll see that it mimics or it draws in the general patho that we talked about in prior slides. Specific to duodenal ulcers, it's not until food enters the duodenum, which 2 to 3 hours after a meal, that a patient will experience pain. So drinking milk or eating buffers the stomach acid, as well as taking antacid will help to decrease the pain associated with duodenal ulcers, but it usually returns 2 to 3 hours later. In the case of gastric ulcers, because eating leads to acid secretion and because the ulcer or denuded area is in the stomach, that exacerbates pain. In reference to GI bleeding, hematoemesis or vomiting up blood, melena, black tarry feces because of the presence of blood, or hematochezia, blood in the stool, can occur with either duodenal or gastric ulcers. The figures included here are showing you a duodenal ulcer on the left. This is actually called a bilateral or a kissing duodenal ulcer, and this is a result of a person using NSAIDs. And on the right hand side, it's depicting a gastric ulcer. Management or treatment of peptic ulcer disease include proton pump inhibitors such as omeprazole to block acid secretion, sucralfate to form a protective covering over the injured mucosa, antibiotics such as clarithromycin or amoxicillin to help eradicate H. pylori infection. Often what's recommended is to give bismuth compounds with antibiotics. But remember, they're going to turn the stools black. So warn your patient that that's going to happen. The stools will appear as melena. Antacids, aluminum hydroxide, the alkaline substances, they neutralize the stomach acid. Then there's the H2 antagonists such as ranitidine, which blocks H2 receptors in the stomach, and that decreases acid production. And then there's misoprostol, which is a synthetic form of prostaglandin that's given. So that's going to help with mucus production and increasing bicarb production. And you also want to advise your patients, if they're smokers, to stop smoking, and if they're using NSAIDs, to stop using NSAIDs, and to try to reduce their stress levels as much as possible. When peptic ulcer disease goes untreated or is poorly managed, complications that can occur are hemorrhage, which can occur due to erosion of an ulcer into an artery or a vein. Obstruction of the pylorus can happen. It's caused by edema. Then there's perforation. That's caused by the ulcer eroding through all layers of the stomach and the duodenum wall. So you want to monitor for symptoms such as severe abdominal pain, rigidity in the abdomen, distension, absent bowel signs, and signs of shock. Dumping syndrome is another complication. It's caused by rapid emptying of hypertonic chyme into the small intestines. And what happens is that an osmotic pull of fluid is created from the vascular compartment into the small intestine, and that's going to lead to a decrease in blood volume, which will cause hypotension. And whenever we have a hypotensive state, dizziness will follow. And in terms of the heart is going to try to compensate because of this lowered blood pressure. So you can expect an increased pulse rate. Osmotic diureses also occur, and that causes intestinal dilation. So the patient will present with nausea and vomiting as well, and also abdominal cramping and diarrhea. Hemorrhage, we discussed, but I just want to point out that it's caused by a bleeding of the granulation tissue and or again erosion of the ulcer into the artery or the vein, and only 15-20% of persons will experience that, but that one is evidenced by hematoemesis or melena. This concludes the discussion on pathophysiology of the stomach. If having questions, please contact me at halef@hawaii.edu.